risk factors. We have with us Dr. Rashmi Yadav. She's a research associate in AIMS, All India Institute of Medical Sciences, New Delhi. She's BSc in Life Sciences, MSc in Biotechnology, and PhD in Physiology. Thank you very much, ma'am, for accepting our request and delivering a lecture on this very important topic related with every human being. How to do this, how to understand this, and how to basically get out of these risk factors. This is the only request we will hear from you, and we'll try to understand how we can utilize this lecture in our daily life. We have with us our Honorable Shri B.N. Dikshit, our Director Legal Metrology. As we are all aware, he has done a lot of work for the legal metrology fraternity in our country. We are going to be the first nation, first legal metrology in the world, which will be disseminating time very shortly, which was done, initiated by Shri B.N. Dikshit Saab during his leadership, during his visionaryship. We have done this job and we are working on it. So a lot of other things like OIML, like state strengthening, he has done a lot. I would like to request our Honorable Shri Dikshit Saab to kindly speak to us and motivate us for doing this type of activities in future. Over to you, sir, please.
Thank you, Sri Ashutosh Agrawal ji, Director Legal Metrology, Government of India, for organizing these very programs. And this Saturday series program is very interesting for the industry people, scientists, legal metrology officers, and all that very things. You are selecting topics which are directly related with the legal metrology, indirectly related with the legal metrology. All these things are very interesting. And today's topic is also very interesting. It is related with every human beings. I hope that everybody will enjoy and will take interest in this very topic from Dr. Rashmi Yadav, who is scientist from All India Institute of Medical Sciences. And I think her lecture will give a boost to we people because everybody is having the problem of this heart and lungs and so many other type of things. So I hope that her lecture will provide a good knowledge to all of us. This is very good time for the Happy New Year, sir. And this series of lecture is at the time of the New Year. I wish Happy New Year 2026 for all the people who are participating in these very programs. I wish for the success of the programs. I welcome Dr. Rashmi Yadav also. I request Dr. Ashutosh Agrawal ji to initiate the further initiative to organize this very program. Thank you, Ashutosh ji.
Thank you, sir. Thank you very much for your kind and motivating words. Thank you very much. Now, I'd like to request Dr. Rashmi Yadav to kindly enlighten us with their vast knowledge and experience. Over to you, ma'am, please.
Good morning, everyone. And I'm Dr. Rashmi Yadav from Department of Pediatrics, working as a research associate. And I welcome you all to the Legal Metrology Lecture Series. And I would like to thank Dr. B.N. Dikshit and Dr. Ashutosh Agrawal for giving me the opportunity to speak on this prestigious platform. And so I'll be talking about the biomarker estimation in individuals with cardiovascular risk factors. So I'll be talking about the cardiovascular diseases, basic definition, the basic pathophysiology involved, the biomarker definition, types, and its importance, how they are related to the cardiovascular risk, what are the basic method for estimation of biomarker, and the steps, quality assurance steps that can be used while estimating biomarkers. And further, I'll be concluding the presentation. So if we look at the cardiovascular diseases, which we all know as a heart disease, It refers to a group of conditions that affect the heart and blood vessels, which we know as veins and arteries in our blood. It is a leading cause of death worldwide, and it accounts for approximately 30% of global deaths and around 20 to 25% mortality in India. It is caused by the accumulation of fatty deposits, that is atherosclerosis in the arteries, and that can increase with the risk of blood clots associated with the damage of arteries in various organs, including heart, brain, and kidney. Now, if we look at this diagram, we can see that during our early age group, there is a healthy blood vessel, and with the progressive age, there is a progressive deposition of fatty acids, which further leads to the progressive atherosclerosis, leading to the blockage of the arteries, leading ultimately resulting in heart damage. This atherosclerosis of cardiovascular diseases basically starts at a very young age, and it progresses over a time. It doesn't happen all of a sudden during our life. If we look at this diagram, if look at this graph, we can see that here it is the age, and here it is the progressive development of the blood vessels. So we can see that initially it is a healthy blood vessel, and then there is in the later stages, that is around the age of 30 to 40s, there is a calcification of the vessels and complicated lesion forms, and there is then thrombosis of the arteries and veins, leading to a infarction or stroke. So what we can see from this, infer from this graph is that this process or progress of development of the disease allows sufficient time for screening and early detection of cardiovascular risk in high risk individuals, and therefore it is crucial for personalized prevention and management of the disease. What we want to say from this slide is that we have a sufficient time during which a cardiovascular disease can be diagnosed. So if we look at the traditional risk factors which are involved for the cardiovascular disease, there are some modifiable and non-modifiable risk factors. Like if we got the age, the gender, and the genetic factors are non-modifiable. However, there are some modified risk factors like obesity, diabetes, hyperlipidemia, hypertension, non-alcoholic fatty liver disease. These all factors can be modified to prevent cardiovascular disease. Then there are certain behavioral risk factors also which contributes to the cardiovascular disease, like smoking, drinking, and low level of physical activity, sedentary behavior, unhealthy diet, and sleep disorders. Now, there could be a stress and depression and some socioeconomic factors also which could lead to cardiovascular disease. Now, there are some emerging risk factors about which I'll be talking in this presentation, like which are related to the pathophysiology of the cardiovascular diseases. The pollution is also one of the major contributing factor which is emerging nowadays. And if we look at the pathophysiological process, there is a macrophage activation, inflammatory immune cell response, leading to the extracellular matrix degradation, and these all the processes all together lead to the plaque rupture or platelet aggregation and oxidative stress in the blood vessels, leading to the fibrosis of the blood vessels. Now, all these mechanisms all together lead to the thrombosis or inflammatory response, and ultimately the myocardial remodeling, leading to the cardiovascular diseases. So what we can infer from the pathophysiological process, that different molecules involved in these different pathophysiological processes can be used as a biomarker for the early detection of cardiovascular diseases. Now, why biomarkers are needed for the cardiovascular risk prediction? Why traditional biomarkers cannot be used for early detection of cardiovascular diseases? Basically, the traditional risk factors like age, blood pressure, cholesterol, smoking, diabetes, these all lack the specificity which is needed to reliably predict individual risk of cardiovascular disease. These factors become abnormal only when a significant progression of a disease has occurred. So these factors basically lead to the misclassifying the individuals who may not actually be at a risk. So nowadays, the development of biological markers have become as an important issue for assessing the cardiovascular risk. For example, the low density lipoprotein cholesterol or the basic lipid profile that we all get done are insufficient to stand alone as a predictor of cardiovascular diseases. The individual with normal low density lipoprotein cholesterol levels can still develop cardiovascular diseases. And the CRP, which is the C reactive protein, is also an important marker which is being performed nowadays. It can also be released during different infections or injuries. So it is also not a specific marker for a cardiovascular diseases. Therefore, accurate measurement of biomarkers with a strong methodological principles may enable a more precise risk assessment of cardiovascular diseases, and it may help in earlier intervention and improved patient outcomes. What are biomarkers? These biomarkers are the characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic responses to a therapeutic intervention. And the accuracy, precision, and high sensitivity and specificity are the important characteristics of an ideal biomarker. The biomarker can be derived from a whole blood or saliva or urine or fecal matter, from a cerebrospinal fluid, amniotic fluid, or tissues and cells. These are the basic sources of biomarkers. And the biomarkers could be of different categories, like biomarker can be a protein biomarker, a genomic biomarker, carbohydrates and lipids and metabolites, depending on the stage of the pathological process we are trying to study. Now, if we look at this diagram, this gives a whole picture of the how cardiovascular disease occurs and what all molecules are involved in the cardiovascular diseases, and at what stage we can diagnose which marker. So this picture is basically the shows a list of emerging biomarkers for detection of cardiovascular diseases. Now, if we start from here, during our early ages, the lifestyle and the genetic factors results into a certain metabolic conditions, disbalance in the metabolic conditions like insulin resistance, hypertension, endothelial dysfunction, oxidative stress, and dyslipidemia. And during the early stages where the cardiovascular disease has not occurred, so these conditions ultimately lead to a condition known as metabolic syndrome, which is basically a precondition before the occurrence of cardiovascular diseases. And further, when these conditions occur for a longer duration, results later into a cardiovascular diseases. So these conditions can be diagnosed by different biomarkers. The biomarkers can be protein-based biomarkers, for example, protein-based biomarkers leading to inflammation, oxidative stress, for example, tumor necrosis factor, interleukin 6. Then it could be a lipid-derived biomarker, for example, low density lipoprotein cholesterols, and then certain enzymes are also diagnosed. Then there could be a disease biological marker. Then there are genome based markers and carbohydrate biomarkers and nucleic acid derived markers. So there is a huge list of biomarkers. All these are not standardized, they are being worked upon, but there are certain biomarkers which are now considered as a biomarker for cardiovascular diseases. Now, if we look in the detail, like inflammation and oxidative stress, on the basis of pathophysiological process, inflammation and oxidative stress are the two important mechanisms which are nowadays being explored for the biomarker estimation. The common biomarkers are the cytokines and inflammatory and anti-inflammatory cytokines. And in case of oxidative stress, the common biomarkers used are oxidized. Instead of estimating the normal cholesterol levels, the oxidized low-density lipoprotein cholesterols are measured. Urinary and plasma isoproteins are used as a marker for lipid peroxidation. Now, there could be a different types of biomarkers. The biomarkers, depending on their clinical utility, can be a diagnostic biomarker, which allows the screening of a healthy patients, that is the presence of a disease. Then a biomarker could be a prognostic, which could be used for estimating a risk of disease that helps in the overall patient survival and independent therapy. And it allows the monitoring of disease status and detects the reoccurrence of the disease. Then there could be a predictive biomarker, which is used to identify treatments which is likely to be effective and guides the initial treatment decision making. And basically to test, it is used to test the response to the treatment. Then there could be a pharmacodynamic markers, which could be used for drug interaction with its target, and it determines the degree of the drug response that guides the treatment decision making in real time. So if we look at the examples, the troponin, which is the well-known marker, and the increase in troponin levels to a certain degree is used as classically used in a acute myocardial infarction. Then, as we most of us will be must be aware that statins, which is a cholesterol lowering drug, is mainly used to reduce the cholesterol levels in the blood. So serum cholesterol levels, they changes with the drug administration. So these can be used also as a biomarker to guide the therapy to reduce the risk of CVD. Now, if we look at the common detection method for biomarker estimation, now to establish a protein as a disease protein or any biomarker, disease biomarker, its accurate, sensitive, and reproducible detection and quantification in large number of samples is necessary. The most common methods for protein biomarker validation are enzyme-linked immunosorbent assays. They are critical diagnostic tool for assessing cardiovascular risk, and they are used to detect and quantify specific biomarker that indicate myocardial injury, inflammation, or heart failure. They are highly sensitive and reasonably specific for the detection of protein amounts with concentration ranging from nanogram per ml to picogram per ml. Now, if we look at the role of metrology in biomarker estimation, so metrology, the science of measurement, provides a foundational framework involving quality assurance and quality control by ensuring that enzyme-linked immunosorbent assay results are accurate, reproducible, and comparable across different laboratories and timeframes. In estimation, the metrology ensures that the detected concentration reflect the true biological state rather than the analytical noise. Now, if we look at the quality assurance, all the basically all the planned and systematic activities to provide confidence that the results are reliable, including adoption of sound practices, the selection and transport of specimen, recording and interpretation of results. So these are the certain steps which are taken care of to ensure that the results are accurate and reliable. So here we can see it is a basic quality assurance cycle that we use in a clinical setting. It basically comprises of three phases: pre-analytical, analytical, and post-analytical phase. In case of pre-analytical phase, there is a proper patient preparation and sample collection. Then there is a sample recipient and transportation. And further, then in the analytical phase, the quality is controlled and the test is performed. And in the post-analytical phase, there is a reporting and record keeping of the test. Now, this quality assurance is basically enhanced by the metrological principles by enhancing metrological traceability. That is, it links ELISA results to internationally recognized standards, ensuring that a biomarker concentration measured today is equivalent to one measured in a different facility. Then metrological principles also lead to the standardization and harmonization. It helps to standardize the reference measurement procedures and reduce between method variability often caused by different manufacturers using different antibodies for the same biomarker. The measurement uncertainty, that is quantifying measurement uncertainty, also allows the laboratory to determine if biomarker level is within the range of the experimental errors. Now, if we look at the pre-analytical phase, it includes all the processes from time a laboratory request is made by a physician until the sample is ready for the testing. So if we look at this picture, there are basically three steps: the patient identification and requisition, where a proper information and detail of a test should be done. And then followed by that, there is a patient preparation and sample collection, where proper care should be taken care of for tourniquet application, like during the withdrawing of the blood, a proper tourniquet application site of vein puncture and should be taken care of. Then there should be a not be a improper mixing or withdrawal of a blood, and the patient condition should be appropriate while collecting the blood samples. Then sample transport and storage, where the labeling of the samples and refrigeration of the samples needs to be taken care of. Now, there are certain errors which can occur during this process. The inadequate test or inadequate patient information collected and inadequate patient preparation needs to be taken care of, that might occur at the time of the analytical or post analytical phase, that can result in a error during analytical and post analytical phase. Now, before conducting the procedure of blood sample collection, a proper consent also needs to be taken from the patient. The sampling time of the patient should be around 7 to 9 a.m., that is around 12 hours of fasting. And there should be no therapeutic or diagnostic intervention before the collection of the sample, and dietary restrictions for blood lipid and sugar should be taken care of. Now, if we come to the analytical and post-analytical phase, the workflow for biomarker estimation. Now, for detection of soluble proteins, now if we see once the blood is collected, here's the picture of withdrawing of blood at the proper site. Once the soluble proteins are secreted into the circulation, they are harvested from a whole blood by a venous puncture. Then the serum or a plasma from a whole blood is extracted. That is done by centrifugation of a whole blood at 2000 revolution per minute for approximately 20 minutes. The sample measured directly, the samples are measured directly or stored at minus 80 degree for further analysis using ELISA. Now, what is ELISA? Enzyme-linked immunosorbent assay. It is a plate-based immunoassay based on antigen-antibody reaction, where an antigen antibody of interest is absorbed onto a plastic surface. An antigen is recognized by a specific antibody, that is why we say it as an immuno, and this antibody is recognized by a second antibody which has enzyme attached to it, that is the enzyme linked, and some substrate is added to the secondary antibody attached to the enzyme, which reacts with the enzyme to produce a colored product, which is then measured by the spectrophotometer. Now, there are basically different types of ELISA: non-competitive, competitive, and this non-competitive can be further categorized into direct, indirect, and sandwich ELISA. If you look at the direct ELISA, the antigen of interest is directly coated onto a plate, where a antibody conjugated to the enzyme is added to the antigen, and the substrate is added to detect the color. There is indirect ELISA, whereas antigen is coated antibody, which is then detected conjugated to the enzyme, and a substrate has it for detection. Then there is a sandwich ELISA, where the target antigen is bound to a capture antibody for antigen detection, or capture protein or antibody detection is added to form a sandwich, and which is conjugated to a detecting antibody, creating a sandwich. Then there's a competitive ELISA where there is a competition between the binding of a sample antigen and a conjugate antigen to a specific amount of antibody. The more antigen in the sample, the less conjugated antigen binds and the lower is the assay signal. Now we'll be talking about the sandwich ELISA, which is highly sensitive and specific. Now basic equipment and reagents used for performing ELISA is microwell plate, which is a plate of a made up of a polystyrene and consists of a 96 well with a capacity of 350 microliters each. Then there is a multi-pipette channel, which is a 8-channel pipette of 100 microliters, capacity of 100 microliters. And then there is a microplate reader, which is a spectrophotometer that works on the principle of photoelectric colorimetry and have a wavelength range from 340 to 700 nanometers. Then there are certain reagents provided to perform the experiment. So if we look at the commercially available ELISA kit, the human interleukin 6 is a basic interleukin is an inflammatory biomarker used in the detection of inflammation in cardiovascular diseases. So if we look at the commercially available IL-6 kit, here is a set of reagents and a plate available in the kit. Now the list of reagents which are available are microwell plate. Then there is a list of standards which are available, which needs to be reconstituted. Then standard diluent, the standard needs to be reconstituted with the standard diluent. Then there are interleukin 6 controls are available, positive and negative control, which needs to be diluted with the standard diluent. Then there is biotinylated anti-IL-6 antibody and biotinylated diluent. Then there is a streptavidin horseradish peroxidate diluent, and which enzymes are, and then there is a TM-based substrate used, and then stop reagent as a sulfuric acid. Now, if you look at the basic principle, the sample and the controls are added onto a well pre-coated with the anti-human IL-6 antibody. Any soluble IL-6 present in the standard sample or control, it binds to a pre-coated anti-IL-6 antibody in the well. After incubation at certain temperature, the washing step is performed to remove the unbound material or unbound IL-6 material. Now, biotinylated anti-IL-6 antibody is pipetted into the well and it reacts with the IL-6 present in the sample, forming a sandwich, as we can see in this figure. Then the washing step is removed to remove the unbound antibody. Once this step is performed, the conjugate, that is the streptavidin horseradish peroxidase, is added that reacts with the biotinylated IL-6 antibody. And again, after washing, the TMB substrate, that is a tetramethylene benzidine substrate, is added into the well. An enzyme catalyzed reaction occurs that changes the color from blue to yellow, which is directly proportional to the amount of IL-6 present in the sample. So the color is detected through a standard microtiter plate reader, ELISA reader, and a dose response curve of the absorbance, that is at the optical density 450 nanometer versus standard concentration, is generated using the values obtained from a standards. So once the concentration is determined, it is checked for other valid performance characteristics. Now, so the ELISA kit is basically based on a sandwich ELISA, and here is the basic output of the plate, which is used while performing the assay. As we can see, here is the in the initial two rows of the wells, we add the standards and the controls, and here we add the samples in the duplicates to be detected. Now, how the data in the post-analytical phase, how the data analysis is performed. The average of absorbance values is calculated for each set of duplicate standard and control and samples. rated by plotting the average standard on the vertical axis by corresponding the IL-6 concentration on the horizontal axis. Now, the amount of IL-6 is determined in each sample by extrapolating the OD values against IL-6 standard concentration using the standard curve. Now, as we can see, this is the list of standards which are used, the IL-6 known IL-6 concentration, the OD that we have derived from an experiment, and here is the coefficient of variance which is calculated IL-6 concentrations. Now, if you look at the graph, here's the IL-6 concentration and the optical density. This is this linear graph for the linear equation from which the values are derived. Now, the role of quality control in ensuring the accurate results with ELISA test kits. The quality control, which is also a part of quality assurance, refers to the operational techniques included in each assay run to fulfill the requirement for quality. Now, the key quality strategies that are used is that internal quality controls, that like running a known positive and negative calibrator samples alongside the patient samples to check for the errors in the test system, reagents, and operator performance. Then there are external quality control, that is the participating in the proficiency testing program where the external expert assesses your lab results against a third party. Thirdly, the standard curve monitoring, ensuring that standard curve shows expected linearity and detection limits, often using by. Now, there are certain good ELISA practices, that is critical factors and checks that need to be considered while performing the experiment. First of all, one should follow the manufacturer instructions precisely. The samples should basically, for the samples, the frozen samples must be centrifuged to avoid fibrin formation, and there should be a check for a stability of samples. The samples should not be repeatedly freeze and thaw, and they should not be they should be thaw at a proper temperature, or they should be taken out of a freezer at least for an half an hour before the experiment. In case of controls, there should be a run of standards in duplicates or triplicates and include a positive and negative control. Then one should use a fresh and store properly the reagents and bring them to at least to the room temperature 30 minutes before the experiment, and definitely one should check the expiry. Equipment needs to be calibrated 6 monthly or a yearly, like microplate reader to ensure, and there should be a proper washing and temperature control of the equipments also. Then for the pipettes, there should be a correct use of pipette by changing the tips between the sample and the reagent. Then there should be avoidance of a bubble formation. The pipette should not be used against the well, and the volume matched pipette should be used. Then there should be a proper procedure for handling the plate. The plate material should be checked. It should be uniform, and coating of quality should be checked. And there should be no edge effect, that is the variability in the outer wells. For the procedure, there should be a consistent incubation time, temperature, and washing steps. The different reservoirs should be properly labeled, and there should be a consistent operator technique. For reading and calculation, the one should select the right filter and blank reading, and there should be a proper plate back cleaning while taking the reading. So all these steps needs to be taken into consideration before practicing the ELISA for the accurate and reliable results. Now, there could be some problems while performing the ELISA. So they can be broadly categorized into four points. First of all, there could be some problem with the coloration once you have performed the experiment. There could be a poor or no coloration after last step, which could be because that the standard or sample have not been added. The reagent for coloration might not be added, or there could be a contamination of enzyme inhibitor, or there could be a freezing thawing that maturation of a conjugate. Then another factor that could happen is that the satisfactory absorbance was not obtained through coloration, though coloration is apparent to the eye. So for this, a plate reader could not, might have it a plate reader was not adjusted to correct the wavelength or filter. Then there could be issues related to a flat or standard curve is obtained in spite of correction in all the sample wells. So for in that case, the first possibility could be that the standards are not added. Then the absorption of standard decreases when the standard concentration was decreased. It could happen because the order of standard was reversed. The other thing which can happen is that the standard curve was not smooth. So this could happen because the mistake in serial dilution of original standard solution could have occurred. So in case of samples, the assay values were not obtained. That is, the samples gave a lower absorbance than that of the blank. Though, so in this case, inactivation of substances or proteins that of interest could have occurred, or there could be a presence of interfering substance in the sample, or there could be a hemolysis of a sample. So for the assay precision, that could occur is that there could be a variation between two wells in the duplicated. For the variation in the two wells could be that there is a scratching of a bottom of the well during the addition of standard sample or reagent or during washing step, or there could be an insufficient washing or pipetting of the reagents. So all these factors needs to be considered while performing the ELISA, and these are the following reasons which could be used for correcting the assay. Now, how the ELISA kit is basically validated. So there are certain regulatory bodies like Food and Drug Administration and Central Drug Standard or Control Organization, CDSCO, in India that regulates ELISA kit used for quantitative purposes and are validated for precision, sensitivity, specificity, linearity, and accuracy. There is a National Accreditation Board for Testing and Calibration Laboratories, NABL, that accredits laboratory that perform ELISA testing. It ensures laboratory complies with the ISO IEC 17025 international standards, and it also verifies that ELISA assay used by the lab are properly validated and verified. They fit for their intended purpose. NABL assesses the accuracy and precision of ELISA results, method validation and verification data. It also assesses the quality control procedures, staff competency and training, and equipment calibration and maintenance, and documentation and traceability. So there are basically some characteristics that needs to be considered for the validation of the ELISA kit. The first one is the precision. So reproducibility within the assay among individual well on the assay plate is observed as an intra-assay precision. It is evaluated in the 3 independent experiments where each assay was carried out. So in case of this commercially available kit, how the company has validated the kit, this I am explaining the procedure that they have evaluated in the 3 independent experiments, each assay 1, 2, and 3. Each assay was carried out at 6 replicates, 3 duplicates of samples containing different concentration of IL-6. So in 3 in human pooled serum and 2 in supernatant, and 2 standard curve were run on each plate. So the data here, as we see that the data shown is the mean IL-6 concentration and mean IL-6 concentration and the coefficient of variation for each sample. The calculated overall coefficient of variation was 3.6, and it should be ideally less than 5% for intra-assay variation. The inter-assay variation is the assay to assay reproducibility within one laboratory performed on different days. So it is evaluated in 3 independent experiments by 2 technicians. Each assay was carried out in 5 replicates, 3 duplicates of samples containing different concentrations of IL-6, and 3 in human pooled serum and 2 in supernatant. The 2 standard curves were run on each plate, and the data below shown is the IL-6 concentration and coefficient variation for each sample, and the calculated overall coefficient of variation was 7.7, which so ideally inter-assay variation should be less than 10%. Then another factor is the sensitivity or a lower limit of detection. The sensitivity or the minimal detectable dose of IL-6 using diclone and human ELISA kits was found to be 2 picogram per ml. So this was determined by adding 3 standard deviation to the mean obtained when the zero standard was assayed 40 times. Third factor is the specificity, which is also known as a cross reactivity. The analyte of interest is detected without cross reactivity with the other close related molecules. So the cross reactivity can lead to false positive result or inaccurate quantification. So to ensure that the only desired analyte is recognized, panel of other substances is also tested for cross reactivity. So to define the specificity, this ELISA several proteins were tested for cross reactivity. There was no cross reactivity observed for any protein tested like other interleukins and other inflammatory markers like interleukin 1, 10, 12, or TNF alpha. Calibration. The immunoassay is calibrated against International Reference Standard NIBSC and is quantitated in internal. There are reputable Indian suppliers which often calibrate their kit standard again NIBSC or WHO International Reference Material to ensure global comparability. It has been calculated that one BSC approximately 10 picogram corresponds to 11 picogram diclone IL-6. Fifth factor is the linearity. Linearity is the linearity of dilution tests where the sample measured concentration should change proportionally to each dilution. Two independent experiments, two spiked human serum samples with different level of IL-6 were serum, two full dilution, that is 1:2 with two replicas each. So recovery ranged from the ideal recovery ranged from 70 to 130%. This mean recovery was 96%. Factor, the other, besides these four major factors, the other factor was also considered the storage stability of the samples. The aliquot of spiked serum and spiked medium were stored at minus 20 degrees Celsius and plus 2 to 8 degrees Celsius and room temperature at 37 degrees Celsius, and the IL-6 level determined after 24 hours. So what was found is that there was no significant loss of IL-6 reactivity storage at 2 to 8 degrees room temperature and at room temperature. Then freeze and thaw stability was also checked. The aliquots of spiked serum and spiked medium were stored at frozen minus 20 degrees Celsius and thawed up to 5 times, and the IL-6 levels were determined. There were no significant loss of IL-6 reactivity after 5 cycles of freezing and thawing. Then the expected serum values. A panel of 20 human sera were tested for IL-6 and all were below detection level of 2 picogram per ml. The advantages of the ELISA technique is that it is highly sensitive, high specific, relatively cheap, and requires small amount of reagents, and the detection is comparatively easy to other assays, and the results are reproducible. Challenges in biomarker measurement. The pre-analytical, there are certain challenges which are involved in the biomarker measurement is no emerging field, and it has not been completely used in the clinical setting, but it is in the in its budding stage. So there could be certain factors which are challenges in the which are challenging in the biomarker estimation. There is a pre-analytical variable, that is the inconsistent sample collection, processing, which involves freeze-thaw cycles, storage, and handling introduce a significant noise that makes it hard to find a true value. Then there are analytical and assay issues, like different assay platforms yield different and varied results. So then there is endogenous interference, that is the variable level of other substances in the cell can affect the measurements. So therefore, proper extraction of the sample is very crucial step which needs to be standardized. Then there is a reproducibility issues, like ensuring a consistent result across different labs is difficult and is in the process of standardization. Then there is a disease heterogeneity. Disease manifests differently in different individuals. So it affects the biomarker levels. Therefore, this needs to be worked upon, that how it can be standardized in different stages or different individuals, stages of the diseases. The dynamic nature. The biomarkers can change with the disease stage or treatment or the external factors like diet and environment. How these biomarker estimation will be affected, these factors need to be worked upon. Then there could be a other factor like low concentration. Many important biomarkers exist at extremely low concentrations also, so making them hard to be measured accurately. So this is also a challenging uh, for in case of biomarker estimation. The solution and approaches could be that there could be an implementation of a standardized operating protocols, use of advanced technologies like multiplex or luminex to measure multiple markers from a single samples to reduce the variability, and by employing the computational tools for data analysis and noise reduction. Now, how these biomarker estimation can help in a clinical setting, validated or so improved cardiovascular risk stratification by early identification of high risk individuals. The proper biomarker estimation at proper stage could give information which could be utilized for improved cardiovascular risk stratification. It could help to devise a better preventive strategy and a personalized treatment for evidence-based clinical decisions. It could also help in monitoring a therapeutic response. Like once a biomarker is estimated, a therapeutic intervention is given, and then again a biomarker can be estimated, which could show that how therapeutic response is achieved. Then it could ultimately help in the reduction of the cardiovascular events. So in the end, I would like to conclude that the biomarker estimation is vital in cardiovascular risk assessment. Metrology ensures the measurement accuracy and comparability of results, and standardized approaches improve clinical reliability, which is essential for modern cardiovascular care. These are the differences that I have used, and thank you so much for patient listening.
Thank you, ma'am. Thank you very much for this brief and wonderful presentation. I would like to request you, we will place this video on our website as well as this
Yes.
PPT with your kind permission.
Yes.
Atulji and RSL Ahmedabad, I would like to request all the participants to kindly switch on their video and switch off their mic, please.
Yes, sir. So please unmute yourself.
I'm sorry. RSL Ahmedabad, can we make the participants analyst?
बात नहीं कोई बात नहीं
Yes, sir.
Thank you. Thank you. Please.
Give me 2 minutes, sir.
Thank you.
Any questions, sir?
If anyone wish to ask anything, the floor is open to all. You can speak.
So they are not asking for the list of the factors. They are just
So please unmute yourself.
Thank you. Thank you very much. I would like to thank all the participants and our expert of the day, Dr. Rashmi Yadav. Thank you very much. We will meet again next week next Saturday with a new topic. Thank you very much. Thank you
Thank
all.
you, sir. Thank you
Thank
all.
you.
Thank you
Thank
so
you very
much.
much. Thank you.
To have a brain, one competent. No,